All right, today we're diving into something called foot drop. It sounds kind of straightforward, right? But it's actually a fascinating medical puzzle. And if you get it wrong, well, the consequences can be huge. So let me ask you this. How could a simple habit, something you probably do every day without thinking, like crossing your legs, how could that lead to not one, but two totally unnecessary back surgeries? It sounds crazy, I know, but it's a real story and it really shows you what's at stake here. Okay, so first things first, what even is foot drop? Well, it's not actually a disease. Think of it more like a symptom, a sign that something else is going on. Basically, you can't lift the front part of your foot. This makes walking really awkward. You might find yourself lifting your knee up high, almost like you're climbing stairs, and your foot just kind of slaps down on the ground with every step. People often say it makes them triple. So, when a doctor tries to figure this out, they have to become a bit of a detective. They're trying to find the source of the problem. And a great way to think about it is like faulty wiring in a house. Is the issue at the fuse box, the main source, which in this case is the nerve roots in your lower back? Or is the problem somewhere down the cable, a nerve that's running all the way down your leg? Now, here's the tricky part. These two problems can look almost exactly the same. They both cause foot drop. But there is one tiny, super important clue that a good clinician looks for. It all comes down to which way the foot is weak. If the problem is coming from the spine, the weakness is usually when you try to turn your foot inward. We call that inversion. But if the problem is that nerve in the leg, the weakness is when you try to turn your foot outward, eversion. It seems like such a small detail, right? But as you're about to see, getting that one thing right makes all the difference. And this diagram really helps you picture it. So you can see our fuse box right there, the L5 nerve root, tucked away in the lower spine. Then you've got the cable. That's the peroneal nerve. See how it travels all the way down and wraps right around the top of that bone near your knee? The thing is, right at that spot, it's super close to the skin. There's not a lot of padding, and that makes it really, really easy to squish or put pressure on. Okay, so let's get into a real-life story to see what happens when a doctor confuses these two suspects. It's a pretty powerful cautionary tale for everyone involved. So this is what happened to a 53-year-old nurse. Her story starts with a simple fall, which leads to leg pain. They do an MRI, they see some issues in her spine, and boom, they diagnose her with a spine problem. Seems logical. So she has back surgery. But her pain just gets worse. So a month later, they do a second surgery. And guess what? Still no relief. And we're not talking about a little bit of pain here. The actual case report described it like this, and I quote, like a screwdriver being driven into her left lateral ankle. Just imagine that for a second. That's what she was living with, day in and day out, while everyone was convinced the problem was in her back. So let's recap. 2 back surgeries, countless injections, months of physical therapy. And she wasn't better. In fact, she was worse off. She couldn't even do her job as a nurse anymore. The entire treatment plan, which was aimed at the wrong suspect, had been a complete and total failure. But then, finally, a different clinician saw her. And the clue that solved the entire mystery, it wasn't hidden in a high-tech MRI scan. It was something way, way simpler. This clinician just watched her. They noticed how she sat in her chair. Turns out she had a habit, a reflex really, of always crossing her legs. And that one simple act was putting constant daily pressure right on that peroneal nerve at her knee. The problem was never the fuse box in her back. It was the cable in her leg all along. So, after all that, after 2 major surgeries and nearly a year of absolute agony, what was the solution? It was this. Just stop crossing your legs. That's it. It's so simple, it's almost unbelievable, right? But the impact was massive. Just 2 months. That's how long it took for her symptoms to completely disappear when she got the right advice and stopped squishing that nerve. Think about that. 2 months of a simple change versus almost a full year of painful, expensive, and useless treatments. Okay, so that's a pretty dramatic story, for sure. But you might be wondering, was that just a one-off, a complete fluke? Well, let's zoom out and look at the bigger picture. We're going to look at some data from a huge study that investigated what actually causes foot drop. So a group of researchers analyzed the cases of over 1,000 patients, 1,022 to be exact, and they collected this data over 18 years. So this isn't just a small snapshot. It gives us a really good, solid understanding of what's causing foot drop out there in the real world. So let's dig into what they found. The third biggest cause is probably what you'd guess: falls, accidents, that kind of trauma. Makes sense. The second biggest cause is those lumbar spine conditions, our fuse box problem. But the number one cause, the most common reason people in the study had foot drop, is something you might not expect at all.
Yeah, you're seeing that right. The single most common cause wasn't an injury, it wasn't a disease, it was a complication from a procedure that was supposed to help: lumbar spine surgery. It's sometimes called failed back surgery syndrome. It's this tragic, ironic situation where the treatment actually becomes the problem.
And if you break down the data even further, you see some interesting patterns. For older patients, say in their 50s and 60s, foot drop is more likely to be related to spine or hip surgeries. But for younger folks, especially men, it's way more likely to be caused by trauma, things like accidents or sports injuries.
So what this all comes back to really is our main theme. Diagnosis is detective work. It's not just about sending someone for a fancy scan, it's about patiently putting all the pieces of the puzzle together.
So, what does that detective work look like? Well, there's a pretty clear playbook. Step 1, a really thorough history. A doctor needs to ask about everything. Habits like crossing your legs, or maybe squatting a lot for work, or even if you've lost a lot of weight recently. Step 2, a hands-on physical exam. You know, there was a study that showed a simple strength test for the hip muscles could tell the difference between a spine problem and a leg problem with 95% accuracy. That's huge. And then only after all that comes step 3, using scans and nerve tests to confirm the diagnosis, not to make it from scratch.
You know, the doctors who wrote about that nurse's case really said it best. They said her story demonstrates the importance of a thorough clinical examination. That's the key. That exam is the foundation. It's what stops that first mistake from turning into a whole cascade of errors, like unnecessary surgeries.
Which really leaves us with one final thought to chew on. We live in this amazing age of high-tech scans and incredible medical technology, but is it possible that the most powerful, the most important diagnostic tool we have is still just a simple conversation? The simple act of listening to and actually seeing the person sitting right in front of you?